Our defense against the outside world is in multiple layers. Our first defense is actually barrier methods. This is skin, mucous membranes that keeps pathologic organisms, invading bacteria, COVID, it keeps them out. But eventually these things penetrate. Viruses and some types of infections then can mutate the DNA within our cells, and sometimes that results in cancers. But so do toxic substances. Anything that's a mutagen and can damage our DNA can result in a cancer. Our immune system has the ability to detoxify the environment and destroy the cells that are showing mutations and malignant behavior. So there are two general types of immune defense. There's the innate response, which is your quick but non-specific response to an abnormality. And this is usually IgM antibody-based, but I'll go into other effector cells. And then the more specific and more potent defense is called the adaptive response. And it's the second wave. It's once the immune system has figured out what's gone wrong, it marshals a bunch of different cells, heavy on the T cell response, to get a more thorough and more definitive attack against the malignancy or invading organism. So one of the major problems with the immune system is its ability to recognize the difference between self and non-self. How does it know what is a normal cell from a cancer cell or a mutated precancerous cell? How do we get the immune system to tailor itself against the malignancy? Inflammation is the result of an active immune system. And many times you'll hear about reducing inflammation, reducing stress on your body and your immune system in order to, make you feel better and prolong longevity. Well, the problem is you don't want to suppress too much, because the things that suppress inflammation suppress our active immune system and can predispose us to malignancy. And so chronically immune suppressed patients, whether it's an autoimmune disorder or drugs for whatever reason, over prolonged periods can actually give cancerous mutations a way in, a survival advantage, a way to beat our immune system. So we have to be careful what's beneficial and what's not. So in basic immunology, how does the immune system communicate with other cells and within itself, within different effector cells? And that's by using proteins called cytokines and eicosanoids. These are proteins that are released by injured or infected cells that are basically in distress, and that can cause fever, redness, increase the blood flow. And then leukotrienes are released, which attract effector cells, which in your first wave non-specific response will be neutrophils. There'll also be platelets, which are traditionally thought of as clotting cells, but they can coat a cell and make it inert so that it can't invade or destroy other tissue. One of the definitions of malignancy is that it has to reproduce itself even though the rest of the body is sending signals to it to stop reproducing, and cause damage to normal tissue, whether that's invasion and destruction or by releasing chemicals and proteins that affect other parts of the body in a negative way. So in this initial non-specific response, like with neutrophils, platelets, and non-specific antibodies, the body tries to put things off until it can marshal its reserves or major effector cells. Cytokines, that's the communicating proteins, and interleukins, which affect the white cells, are released. Interferons also are released. These are the chemicals in the immune system that cause fever, fatigue, malaise. They're traditionally thought of as fighting off viruses, but they also inhibit protein synthesis. And if a cell can't synthesize proteins, it can't do its housekeeping function, and eventually it dies. So in some diseases, we use interferons to modify the immune system for long periods of time. And then there are chemokines. Chemokines promote chemotaxis, which is basically cell movement, and it gets the immune system to move cells from where they are stored, either in the bone marrow or lymph system, and gets them out into normal tissue or affected tissue. Okay, what is this now? All right, so immune responses, there's humoral responses, which I just alluded to with the IgM, which is a non-specific but large antibody. But then there's IgA, IgG, and IgE, and each of these have different roles. IgG is your major antibody against infection. So when you get vaccinated, such as against COVID, you're trying to sensitize the memory cell or the plasma cell in the immune system to recognize what the antigens are from the infected cell, so we can make a fast, specific response with an IgG molecule. IgA is important in defending against things that affect the mucosa, sinus, upper respiratory, intestines. IgE is important in fighting off certain respiratory and GI illnesses that are more parasitic. The growth factors that stimulate these plasma cells and frontline immune cells like neutrophils are GCSF and GM-CSF. These are colony stimulating factors because they were first discovered in culture, where they really stimulate the immune cells to reproduce quickly, and I mean extremely quickly. And they can alter blood flow, they can trigger activity of these cells into the periphery. There is also stem cell factor, which has been synthesized but not in common use. And stem cell factor stimulates the parent cell, the mother cell, which can regenerate itself, but also regenerate any of the cells in the body. It's, again, the holy grail of human biology, because it can heal damaged tissues, it can reproduce itself, and it's very good at repairing damage to different parts of the body. Stem cells are what we look for in umbilical cord blood and in transplant. Stem cell factor is a protein that stimulates those stem cells to reproduce themselves. So complements. Complements are not full cells. They're little proteins that are floating around in high concentrations in the bloodstream, and they're a major component of the innate immune response. These complements float around, and then they can be activated by antibodies and certain cells, and the complements then become active, and I think of them like little Pac-Man. They go rip up membranes, break the membranes, cause fluid shifts at the cellular level, and that can cause the cell to die. They can also coat the cell along with the platelets to deactivate it and prevent it from causing damage to other parts of the body. When complements are activated, they can also affect normal cells. So we see abnormal complement levels in autoimmune diseases like lupus. And when complement is activated, it can affect blood flow. So a lot of people get edema. You'll see a lot of swelling, ankle swelling, hand swelling when the complement cascade is activated. And then comes the cellular response. So in the first wave, neutrophils, but then you have the second wave, which are more macrophages and dendritic cells. So all of these cells can move through the body painlessly. You have no feeling to these cells, and they can move to where they're needed because of chemotaxis, because some injured cell is asking for them to come to this area. Dendritic cells are antigen-presenting cells. They're the cells that come in, figure out what's going on, and then tell the T cell to activate and become like a tank to, really heavy artillery attack of the abnormal cells or tumors. Macrophages come in and swallow up damaged cells and destroy them by phagocytosis, or eating and destroying the cell. And then there are the T cells, which have gotten a lot of news in the last few years as more and more, how shall I say, medications are developed that can activate and manipulate T cells. T cells seem to be key to recognizing self from non-self by checking protein passports, if you will, on the surface of cells. And if they don't muster up, they can directly destroy the cell as a cytotoxic T cell or a natural killer cell, or they can manipulate other parts of the immune system to do the destruction. So B cells are your first wave. These are your cells that make antibodies, that make the first non-specific defense, and T cells are more specific. So this is a decades-old slide from back in my medical school days, but it still holds true. The stem cell has the ability to regenerate itself and generate all the other cell lines. All these abbreviations, this alphabet soup, are the different cytokines that cause one cell to differentiate into the different kinds of effector cells. Whatever the body needs, it looks at what signals are being released by the stem cell and by the damaged tissue in order to create and multiply the cell that's needed to fix the problem. So it's an incredibly elegant system. So the cell signaling becomes critical for normal cell development. So this is just another representation, more modern, of the slide I just showed you. The stem cell makes daughter cells, which then differentiate into all these different effector cells and into normal cells. There are experiments that show that in a stroke patient, if you can get the stem cell to differentiate to a neuron, it can repair the damage from a stroke. It can regenerate kidneys, skin, liver, lung. But how do we tell it what kind of cell, and how do we get that cell to show up in the right place and function the right way? And that's why there's a lot of research being done on cell signaling. And we still have a long way to go. So one of the most famous cancer pathways is called JAK-STAT cell signaling pathway. And we know that certain cancer mutations within the DNA will produce abnormal JAK2 protein which is on the surface of the cells, and that can cause abnormal mutations downstream, which can affect cell growth. And so the tumor cell manipulates this pathway in order to get itself to grow, but inhibit the pathway in normal cells, so it gives itself a growth advantage. What's fascinating is that there are patients with platelet disorders and blood disorders where they produce too much blood and too many clotting cells, platelets, because of stimulation in the JAK-STAT pathway, but they may not have an invasive cancer. And we know that if you have the JAK mutation, you're more prone to blood clots because of the vascular effects of these pathway changes, even before you develop cancer. And so this is one of the things we look for when we see certain abnormalities into the blood and we're worried about blood-borne cancers. So what I was alluding to earlier, passport or cell surface proteins. So this is an idealized B cell. And these are examples of the normal proteins that are on the surface of the B cell that tell the body what kind of cell it is, what its function is going to be, and then how to manipulate this cell. So if I'm stimulating surface immune globulin, then this cell is going to make more antibodies. HLA tells me that this is a cell from my body and not from somebody foreign. And these are the proteins that can stimulate certain functions within the cell, but they can mutate when the cell turns cancerous. So for example, in a chronic B-cell leukemia, you'll see a proliferation of CD19 and 20, and there'll be large amounts of that on the surface of the cancerous B cell. Where if those are missing, then this is no longer a B cell, but mutated into something different. My favorite receptor is the death receptor. All cells have a death receptor. And what's fascinating is if you, as an oncologist, can stimulate the death receptor within a malignant cell, you will stimulate what's called apoptosis. It's a signaling pathway that leads to suicide of that cell. The cell will then kill itself. And that's become one of the highly sought after pathways for drug and treatment development. If you can trigger the death receptor, then the cancer cell dies and you try not to stimulate it in normal cells. And we've actually had a fair amount of success nationally in developing new treatments for that. So I've been rambling on about the immune system, but I want to give you a big overview on how can you kill malignant cells? Because I've heard everything from vitamin supplements to ultraviolet supplements to inhalation therapy. There's only a few ways that you can actually kill a cell. You can modify the environment, you can modify the body's responses, but in order to kill a cell, you either have to mechanically cut it out, and that's the whole career of surgical oncologists. But then how do you know you have it all? Because you can't see at the microscopic level when you're doing surgery. There's cytotoxic, which is the old-fashioned chemotherapies that poison cells, and they do DNA damage. There's radiation-induced necrosis. So that's a targeted therapy. You can't treat the whole body with radiation without damaging normal cells. And so while we do that in extreme cases with total body radiation and a transplant, most radiation is targeted, tries to finely target a specific tumor, like a brain tumor, without damaging the tissues around it. And in order to inflict that damage, the radioactive beam, the ionizing radiation, activates oxygen into a free radical, which causes a lot of membrane damage and a lot of inflammation. So it's an inflammatory death. And then there are other inflammatory induced necrosis. And this gets into your antibody therapies and some of the newer T cell therapies, where you want the immune cells to invade the malignancy and trigger inflammation and necrosis. And the last was my favorite, which was the programmed cell death, where you triggered the cancer to kill itself. So one of the first breakthrough antibody therapies was called rituximab, which is now available as a generic. Different companies make it. It was a major breakthrough in treatment of non-Hodgkin's lymphomas and rare types of Hodgkin's disease called lymphocyte predominant Hodgkin's disease. So what all these cancers have in common is they are mutations of normal B cells into malignancy. And these malignant cells express the surface protein CD20. So with this antibody, which is made from genetically engineered mice, and then the sequence is implanted in yeast, and that makes the rituximab antibody, which is then cleaned up and humanized to attack CD20 specifically. It takes out the lymphoma cells, but also takes out some of the normal CD20 expressing white blood cells. So you'll see patients who've gotten rituximab have a big response, and sometimes it's an allergic type feeling or side effect with the first infusion especially, but then the body quiets down and comes into homeostasis or balance. The CD20 cells that are normal, as they get taken out, you'll see a drop in the lymphocyte count on your CBC, and your peripheral blood count. And you can see a drop in the total white count. And sometimes this can last for months and years after completing therapy and after achieving a remission. It depends on how extensive was the CD20 attack on normal cells, and was the stem cell able to regenerate the normal ones, or was the stem cell also suppressed? So that was the beginning of interest in monoclonal antibodies. Now, monoclonal antibodies can work in several other mechanisms. It can trigger apoptosis by hitting the death receptor. It can activate other effector cells like the T cells. It can generate inflammatory response. And the goal, obviously, is to rip holes into the membranes of the cancer cells and allow them to die. And that can be done through these pathways, but also through the complement pathway. So the history of immune-targeted therapy, one of the major breakthroughs in multiple myeloma has been targeting CD38. So I just talked about CD20, but this target is on the mutated plasma cells or B cells that cause myeloma. Well, the initial concept of targeted therapies goes back to 1897, when, I lost my space. This is when you get click happy. When it was first postulated that you could selectively attack certain tissues without harming other tissues. And then as time passed, we developed more and more experience manipulating the immune system. And now we have very specific antibodies which I'll start talking about a little bit more in detail, that trigger and modify the immune response to behave in the way we want against the cancer without destroying normal tissue. So the mechanism of action in myeloma cells is very similar to rituximab in lymphoma cells. You can have direct attack on the death receptor of the myeloma cells. You can activate other types of cells, such as the dendritic or antigen presenting cell and the cytotoxic T cell, to do the dirty work in destroying the myeloma cell. What's fascinating is that this can continue even when the antibodies are out of the system, but eventually the body comes to rest. So if there's no stimulation of the cytotoxic T cell, it will revert back to a normal T cell, and the antibody response fades away. Just like in a vaccine, after 6 months or so, your antibody levels start to fall off, and the stimulation of your T cells to be hyper responsive starts to go down, and you become more susceptible to either the infection in the case of COVID or in the case of myeloma or malignancy. And that's one of the reasons we think that we're successful in controlling these chronic malignancies, but not curing them. The difference between a remission and a cure is time. If you kill everything that you can detect, that's a remission. But a remission that lasts for decades, for the rest of your life, that's a cure. We used to make the cutoff at 5 years based on research, because the funding for the research trials used to run out at 5 years. But now, through other research funding sources, we're able to track things out decades, and we can see in many cancers that we thought were cured, there can be late relapses. And again, that can be due to abnormal gene mutations that were silent and then start to express themselves, like the JAK2 pathway. So in multiple myeloma, it's a cancer of the plasma cell. Plasma cell is what makes antibodies to defend against infections. And so when it's mutated, it's not making healthy antibodies. And so it's making defective, non-functional antibodies. And that's what we're looking for on the blood tests that myeloma patients are getting all the time. As we understand different cancers better, we come across more and more tumor markers. And you'll hear about all kinds of tumor markers for colon cancer, stomach, breast. I mean, there's a large list of them, and it's the same concept as in the myeloma. The myeloma is the classic example. Because the cell isn't working properly, it releases an abnormal protein. We're able to detect that, and therefore we know that there's still malignant cells somewhere, even if we can't find them on scan. And so that's why we're watching all the time for these tumor markers to crop up positive. The other issue with these cells is you may not be able to see them, but you may be able to treat them by using your suppressive therapy, your antibody therapy, your Rituxan, your durvalumab, what have you, to target the cells even before you see them. And that's the concept of maintenance therapy, is chronic suppression and destruction of cells that you can't detect on your scanners. So besides antibodies, there are the, how shall I say, the adaptive molecules that the immune system uses to adapt and modify the response to malignancy. And one of the first ones out was alpha interferon, and it actually was a big breakthrough in the 1980s. And it was considered the first method of curing hairy cell leukemia and the only effective method of controlling metastatic melanoma back in the day. Since then, more modern and effective immune therapies have been developed, but alpha interferon was the first. The second big breakthrough in malignant melanoma was high-dose interleukin-2, which is another cytokine. So high-dose interleukin-2 was used in melanomas and then really caught hold as a treatment for advanced metastatic kidney cancers, where surgery, radiation, chemotherapy didn't work. You could stimulate the immune system with interleukin-2 at very high levels, but you couldn't be specific. This was a broad stimulation of the immune system, not specific. So sometimes you got into trouble with side effects of an overstimulated immune system. And I've seen cases of rupture of the left ventricle of the heart, spontaneous rupture of the intestines, because those immune cells, that the little Pac-Man that eats the membranes, decided to go after normal cells instead of the cancer cells. But more often than not, interleukin was effective in controlling and sometimes curing kidney cancers and melanomas. And you can see in the beginnings of our understanding of immune therapy, this is a published clinical trial from 2008, but interleukin had been used going back into the 1980s. And there are patients that got interleukin for a few months and never relapsed. Others had prolonged life, but eventually relapsed. And unfortunately, there were many where they didn't respond. It was really hard to predict if you were stimulating the right cells. Getting into cellular therapy, we learned from the transplant community, which initially was doing bone marrow transplants in order to recover from bone marrow failure states or damaged bone marrows, that if we transplanted bone marrow from a HLA matched donor into a recipient with advanced cancer that could not be controlled with chemotherapy or radiation or surgery, we could actually trigger a graft versus tumor effect. And the new immune system could make antibodies, cytokines, T cells that would attack the malignancy and put them into remission. However, if you overstimulated that new immune system, it could cause graft versus host disease, where it would attack one's own healthy body. And there are many cases of people dying of graft versus host disease and not getting the benefit of graft versus tumor. You just stimulate the proper cell, but in the wrong location. So this is a slide looking at a sclerotic type of chronic graft versus host disease, where you get severe contractures and inflammation of the skin, and it really is disfiguring, and it really impairs normal function. So immune manipulation isn't without its risk. So this is coming back to the cell signaling pathways between graft versus host disease. And I don't want to spend too much time on this, but it's the same pathways that we use to stimulate the immune response against cancer can cause an immune response against healthy cells. So there's a lot of research in trying to separate the attack on bad cells from good cells. And this gets back to, how do you identify self from non-self? How do you identify what is a healthy cell from what is an imposter? And that gets back to the T cells. The T cells are the final mediator, the ones that really control the determination who's a good guy and who isn't. So that gets into this target recognition. It does no good to stimulate the appropriate cell, but then not achieve destruction of the targeted cancer cell because it doesn't recognize it as being bad. And unfortunately, that is all too common. We see that in solid tumors and liquid tumors, bloodborne disorders, that the cancers try to evade the immune system's attack by blocking the effector cell, the T cell, from recognizing it as bad. So there have been major breakthroughs in unmasking the cancerous cell so that the T cell, the effector cell, can find and destroy those cells. These are just a sample of the surface proteins on all of our cells, which can manipulate the behavior of those cells and identify what type of cell they are. So just as an aside, some people have cancers where we try to figure out where the cancer came from. And that was more important in the past than it is now in the modern day. And that's because if you think of cancers, the classic teaching is cancer is a mutation of one of the tissue's cells that goes crazy, then tries to reproduce itself, and over time makes more and more of those cells. And then those cells splinter off and spread through the lymph channel and in the bloodstream and then distant organs. Well, while that's true for many solid tumors, that doesn't explain why some people can have early stage disease, for example, in a breast or a prostate, and then they find disease not in the lymph system, but in sites, far distant. For example, I have a patient with breast cancer where it looked like she had stage 1 disease. And just by serendipity, they did a bone marrow biopsy for an unrelated reason, and they found breast cancer cells in the bone marrow. Wasn't in the bone, wasn't in lymph nodes, wasn't anywhere else. And the explanation is that the cancer gene that triggered, in this case it was BRCA1, that triggered the cancer in the breast, mutated cells in the marrow to become cancerous, or permitted the same mutation that caused the cancer to develop to occur in the bone marrow. There are theories that say it takes 7 steps to go from normal to a mutated cancer cell. If you can, knock out any of those steps by using immune attack or targeted attacks, then you can control the cancer without harming the host. So the drugs that have gotten a lot of media attention in the last 5 years have been the PD-1 inhibitors and the CTLA-4 stimulators. So these are drugs like Keytruda, Opdivo, pembrolizumab, atezolizumab, durvalumab. The list is getting more and more every year. What those drugs do is the cloaking device, the mechanism that the cancer uses to block the T cell's ability to recognize the cancer cell as being foreign or bad. The PD-L1 is excreted by the cancer cell to block that receptor on the T cell and on the dendritic cell, so they don't recognize the cell as bad. You can give an antibody against PD-1 or its cousin PD-L1 and unmask the cancer cell, then all of a sudden the T cells are hyperstimulated and go after the malignant cell. The problem comes in when this hyperstimulated T cell decides it's not only going to hit the cancer cell, but the normal tissues around it. And then you start getting into complications, which are inflammatory and autoimmune type complications, which we treat with steroids and immune suppression. CTLA4 is ipilimumab or Yervoy, which initially was developed for malignant melanoma, but has become a major treatment within lung cancer and is being developed in other cancers. So CTLA4 really upregulates the cytotoxic T cells. So now you unmask the cell, Keytruda, pembrolizumab, whatever, and then you have stimulated T cells, but you add the CTLA4 stimulated chemical or antibody, which drives the hyperproliferation of the T cell response. And you really magnify the response. But you can magnify the toxicity, so you have to be careful. In my practice, when I give patients Opdivo with Yervoy, so those are brands, I usually give them steroids to carry in their pocket, because if they suddenly get a bout of inflammatory bowel disease, colitis and diarrhea from it, the sooner they take steroids to stop it, the better off they'll be and maybe not require a hospitalization. So this is just another schematic that talks about the CTLA4 pathway. So this is a complex slide that basically is telling us that T cells, once they recognize a cell as bad, they can co-stimulate other T cells. They can be switched on by your frontline non-specific responding B cell, but also switched on by an unmasked malignant cell. And then the dendritic cell, which is also called the antigen presenting cell, has the ability to go in and spy on the cancer, basically recognize if it's there or if it's not there, and help the T cell identify the evil mutated cell. So this is an example of two patients in the initial clinical trials with nivolumab, and this is a lung cancer. You can see here, this whole whitish area shouldn't be there. This patient went on to nivolumab in an attempt to prepare the patient for surgery to resect this segment of lung. And you can see that it was quite successful in destroying the tumor, but maybe not completely. There were still inflammatory residual changes, and we couldn't tell if that was malignant or benign. These large purplish cells are the cancerous cells. And what's interesting here is there's an infiltration of healthy nucleated lymphocytes into the tissue where there are malignant cells. And so you see this war going on, basically hand-to-hand combat between the immune effector cells and the malignant cells. This is in a different patient, but the same concept, same finding. Now, how do we know if your cancer is expressing PD-L1? You can't do this on a blood test. It has to be run off the tissue. And so these are special stains that light up the PD-L1 on the surface of the cell. This is a negative, and this is a strongly positive, and this is a intermediate. And this is a higher magnification of the same thing. So there have been studies that insurance companies like to quote in order to prevent you from getting the PD-L1 inhibitor paid for. And it's been shown that if you have high expression of PD-1 or PD-L1 on the surface of a cell, then you're more likely to benefit from these anti-PD-L1 drugs like pembrolizumab or nivolumab. However, one of my best responders was a patient that was intermediate to low on the PD-L1 identification in lung cancer. And she had cancer that had spread to brain, a large 8-centimeter mass in her left lung, disease in the lymph nodes of her abdomen and pelvis. And she would not have made the criteria at the time when insurance companies passed the rule that you had to be above a certain percent in order to get the drug. She only had about 6% expression. However, the insurance company that she hadn't yet made that rule. So we squeaked in because we knew the literature better than their advisors. They approved the drug, and she's now going on 6.5 years out, doing well with only one site of disease where we're suppressing it. The brain lesion is cleared, the distant disease is cleared, she has good quality of life. So it just goes to show these immune histochemical tests aren't perfect, and sometimes you benefit even when they're negative. And so to that end, many cancers, if nothing else is working, sometimes it's worth a shot at immune therapy, because sometimes it works even though your predictive models may be flawed. So these are the survival curves in the initial studies on non-small cell lung cancer. And you can see those that got checkpoint inhibitors, or this PD-L1 pathway, their survival was far superior to the other groups. Even those that had some benefit from chemo did much better than those that didn't get chemo or had no effect. The ones that got immune therapy were superior. So now one of the standard approaches is to use chemo plus immune therapy. The newest rage in the immunotherapy community is CAR T therapy. And in CAR T therapy, we're actually harvesting the T cells. Usually you go through an induction chemo to try and reduce the tumor burden, get the T cells upregulated, then you take them out of the body, stimulate them and modify them within the laboratory, and then reinfuse them. And it's typically a one-time infusion, and it can cause an incredibly brisk response to the immune cancer destruction, but it can also cause a lot of toxicity, lupus-like toxicity. And this really needs to be done at a center that does it every day, because patients can go into comas, they can get brain swelling, they can get really severe inflammatory reactions. Once you control those reactions, I've seen patients where nothing has worked, have been in complete, treatment failure, go into remission, and the remission is long-lived, but they have bad reactions. So this was one of the first, exacetabine gene. Don't ask me to repeat that 3 times, but this is a commercial CD20 CAR T-cell therapy. It has now been FDA approved in certain types of leukemia, predominantly refractory ALL pediatric leukemias, and in diffuse large cell lymphomas. This is now being researched. Modifications of this are being researched in other leukemias, in lymphomas, and even in some solid tumors. Loyola is trying to develop customizable CAR Ts. University of Chicago, Rush, Northwestern is working with industry on developing new ones that what we say is called attack different epitopes. So the one that's FDA approved is specifically for CD19. If you don't have CD19 on your tumor cell, this is not an option for you, but there are other CARs in development. So in the initial study, out of 101 patients where nothing else worked, they had response rates of 82% with over 52% survival at 18 months. That was in the initial paper that led to FDA approval. The comparative group, nobody was alive at 18 months. So it's an incredibly powerful tool, and expect to see that more and more. And the duration of the response is incredible. Many people are still alive that have gone through it. But again, not 100%. And here is the list of all the potential side effects. It's not for the faint of heart. True immune stimulation is going to give you side effects. Are they going to be mild or severe? Depends on your own biologic makeup and your immune system's ability to withstand the stimulation. Cytokine release syndrome is when the immune system is so hyperstimulated that it just releases large volumes of these proteins that I talked to at the beginning of the lecture in order to communicate with other immune cells. This cytokine release syndrome is exactly the same as what we saw in the early days of COVID. So when COVID was infecting people 2 years ago, it would deplete the T cells out of the body by just exhausting them. It would cause this inflammatory storm. Lungs would shut down, livers, kidneys. It would go into these mental confusion states where the brain would swell. And that's how many people died. And initially, we didn't know how to treat this. We didn't have very good tools. That's markedly improved. We now have antivirals. We know how to dose steroids. We have anti-IL-6, anti-inflammatory drugs. This has come a long way in 2 years. But the same concept applies within the immune manipulations for cancer. So CAR T right now is restricted to large cell lymphomas that don't respond to upfront therapy and leukemias. But if you have an advanced cancer, especially hematologic, talk to your doctor because this is a hot area of research. And T cell activation is the name of the game, whether you do it through CAR T or whether you do it through other mechanisms. One of the other hot areas of research are these biphenotypic antibodies. They've now made antibodies that can not only unmask cells, but also stimulate them and can be so effective, you get the CAR T effect without actually taking the T cells out and manipulating them. And these treatments should be available at larger community cancer centers within the next few years. There are already clinical trials looking at the practicality of using these stimulatory antibodies at smaller hospitals and smaller cancer centers where patients don't have to have these huge laboratories that manipulate T cells. So it all comes down to the milieu of the cytokines, the antigen manipulation, and do you have the right effector cell in the right area? So I want to emphasize this is not a one-size-fits-all. Some people's immune systems can't tolerate it. Some people's immune systems don't respond to stimulation. And sometimes the manipulations we use in order to get the T cells to recognize the cancer don't work. And in those situations, you're left with going back to older therapies, surgery, radiation, and cytotoxic chemotherapies. However, expect this area to lead to newer therapies and more targeted therapies because it's unbelievably rich in research protocols. And that's all I have. I can take a few questions. Here's one. Are there certain blood tests for myeloma patients that are best at identifying tumor markers? So in myeloma, the usual tests are serum protein electrophoresis and immunofixation. And what you're looking for is what's called an M protein. The light chain assays, you're looking at those broken antibody parts. And then there are less specific markers called beta-2 microglobulin and LDH, lactate dehydrogenase. LDH is not cholesterol, which is LDL. It's a marker of cell turnover. And you'll see those tests run very commonly in myeloma patients to get an idea of are you progressing or responding.
Great. We had actually one more question come through in a different way. Just one quick one. Can immunotherapy be used in preventative medicine? Can it prevent cancers from forming?
So right now, the simple answer is no, but I think that day is coming because there are that JAK2 pathway, which is a classic cancer manipulation. And I have to tell you, the chief of hematology oncology at Northwestern University, that was his claim to fame, as he was one of the research that identified how the JAK2 pathway causes cancer development. We are now, there are several standard therapies available that target the JAK2 pathway. And right now, those side effects are too severe to allow those drugs to be used as prevention. Let's say you have JAK2, but you don't have cancer. But I think the day will come when we will be able to nullify that pathway without waiting for the cancer to develop. So it's coming.
That's great. All right, does anybody else have any other questions? Don't see any on the chat here. Oh, here we go. How toxic are a patient's body fluids after Opdivo treatments and for how long? That's a great question.
It is a good question. So the body fluids aren't toxic at all. However, the cells within the fluids. So, this is the difference between plasma and serum. Is it cell-free? If it's cell-free, then there is no toxicity at all. If there are cells floating around in there, your effector cells, those effector cells can be toxic. The issue is, how do they get exposed to a non-host? So if my cells are floating around in my serum, those cells should be able to recognize that my body parts are self and not attack them and not be, false flag or friendly fire. If I happen to give that through a transfusion, let's say to another host, let's say mistakenly you donate serum or blood and you have these activated T cells in them, you could cause a major reaction in the person receiving your serum or blood. And that's why, that's one of the reasons a cancer patient can't donate blood or serum. However, if you just cut yourself and bleed on somebody, it's not going to get into their system. It's going to be blocked on the surface and not cause toxicity. How long does the Opdivo effect or nivolumab work? It's different in different people. I've met people who were in the original research study for Opdivo who are now 10 years out and they're still in remission. We don't know if if they had a deep remission and a deep response to initial therapy, or were those stimulated cells still floating around and active this 10 years later? That's being looked at. Unfortunately, that's still a minority of people. The majority of the time, the effect of Opdivo, nivolumab, these PD-L1 inhibitors will wear off within a month.
Anybody else before we wind down here? I don't see anybody. Nobody's typing. So, okay,
Okay,
I'm going to wrap it up then. Thank you for joining us today, everybody. And a huge thank you to Dr. Bear for sharing your expertise and your time. This is so fascinating. So this presentation will be uploaded to our YouTube channel this evening. And the link for the YouTube channel will be available on our Facebook page. And I'm going to put it here in the chat as well. So if anybody wants to go back and take more notes or whatever, they'll be welcome to do that. So I'm going to go ahead and log everybody off, but thank you so, so much, Dr. Bear. We appreciate it.
thank you. Thank you. Bye-bye.